everybody. We're going to talk here about pelvic fractures. I wanted to go over pelvic fractures in its own right just because this is a common problem that you can see, especially in the case of major trauma like a motor vehicle accident. It's also something that you see in falls. So older patients with osteoporosis, ground level fall, probably going to get a pelvic fracture. So this is a very, very, very important topic, especially if you are working in the ED or if you are working in the trauma bay. So just for review, we're going to just quickly look at the bony anatomy of the pelvis. So the pelvis you can think of as two big structures. So the sacrum and the hip bone. So the sacrum is this medial structure right here, and it's just the distal spinal column. And then the hip bone, or os coxae, coxal bone, is comprised of the ilium, the ischium, and the pubic bone. So the ilium is this sort of winged-like structure up here, and it's the most superior part of the coxal bone. And we see both the wing of the ilium, the iliac fossa, and the iliac crest, which is a slightly thicker portion. It's most superior, and it's also important because it's the insertion point for rectus abdominis and a lot of the leg muscles. And so this is going to be a commonly injured site when you have avulsion. The ischium is down here. It's the most inferior portion of the coxal bone. And then the pubic crest up here, which is the medial part of the pubic bone, which they come together both left and right medially to form the pubic symphysis. I also just want to point out, just for reference, the acetabulum here laterally, and that's the insertion point or the articulation point for the femur. The ligamentous anatomy is very complex, and you don't need to memorize it, but what you should remember is that there are a lot of ligaments, and so anytime you get any kind of pelvic fracture, it can also damage the ligaments. And the bone holds the ligaments in place, and the ligaments hold the bone in place. So if you get a fracture of the pelvis, the ligaments are not going to be able to appropriately do their job. And so what I want you to take special note of is these iliofemoral ligaments. The ilium keeps the femur in place. And so if you don't keep the femur in place, let's say you were to take a scissors and cut this ligament here, what would happen is the femur would rotate externally. It would just move into the natural position caused by gravity. And so when we see pelvic fractures, what we see very commonly is external rotation of the leg. The nervous anatomy of the pelvis is also quite complex. We have the lumbosacral plexus running right through the outlet of the pelvis. So the two nerve roots that are most commonly injured are the L5 and S1 nerve roots, and that's because they run the closest to the pelvic bone. And also to a very commonly injured site, which is the sacroiliac joint. L5 and S1 both provide innervation to the common fibular nerve, which is part of the sciatic nerve, and that innervates muscles in the anterior compartment of the leg, which is responsible for dorsiflexion. So if those nerves are lost, particularly L5, if that nerve is lost, then you're going to result in foot drop. These also provide innervation to the cluneal nerves, and the cluneal nerves are responsible for cutaneous sensation of the buttocks. So that's another thing that we commonly see, anesthesia of the buttocks in pelvic fractures. But I would remember that all of the lumbosacral plexus can be damaged in pelvic fractures, and it's just going to depend on the severity. Also remember S2, S3, S4, S2, 3, 4, get your pants on the floor, is responsible for both genital and the anal sphincter tone. So if you have a loss of anal sphincter tone, S2, S3, and S4 are damaged, and that's the pudendal nerve for the anal sphincter. The arterial vascular anatomy, it's not important to know this in detail, but what I wanted to just point out is that it's very rich. There's lots of arteries around the hip. So that brings up a very important point in that when you have hip fracture, one of the big things that we're concerned about is bleeding, hemorrhage. And most commonly, it's not due to arteries, it's due to veins. And actually the most common cause of mortality directly due to pelvic fracture is hemorrhage. So that's important to know. And the arteries and veins that are most commonly injured are the external and internal iliac arteries and veins, and then also these smaller veins and arteries that surround the pelvic bone more intimately. All right, so pelvic fracture is a fracture of the pelvis, as its name would imply, and most commonly it's caused by a ground level fall. And so when you have a ground level fall, most of the time that's going to be a minor fracture if there's one at all. Most people, if they fall from the ground, so let's say you faint or you trip over something, it's not going to cause a fracture. But if you have an older patient, osteoporotic for instance, then yes, tripping over a cord or fainting or something like that can cause a pelvic fracture and can actually cause a really severe pelvic fracture. So ground level fall is the most common cause of pelvic fracture. However, a ground level fall, usually in healthy patients, if it causes a pelvic fracture, it's usually a minor fracture that doesn't have a lot of complications. Now, if you do have a ground level fall in an older or osteoporotic patient, or you have a high energy trauma, so motor vehicle accident, you get hit by a car, which is pedestrian versus car, as they like to refer to it, or a crush injury, or any kind of higher fall, so falling off a ladder, falling off a roof, those can cause really significant pelvic fractures. The mortality rate for pelvic fractures ranges anywhere from 5 to 50%, and that's going to depend on the presence of other complications. So other complications would include an open fracture, advanced age, osteoporosis, additional injuries, because if you're getting into a motor vehicle accident, your pelvis is not the only bone that's at risk. You may have your ribs at risk, you may have your femur at risk, so additional injuries also contribute to the mortality rate. And then concomitant general medical conditions that may complicate the recovery process or the surgery. The most common cause of death related to pelvic fracture is hemorrhage. And so that's going to be really important when we look at the patient when they first come in with a possible pelvic fracture. The most important thing is managing their hemodynamic status. So what is the history in a patient with pelvic fracture? Well, it could be a ground level fall. Usually if there's a significant pelvic fracture, that ground level fall will be in somebody who's elderly or osteoporotic. Anytime you have an elderly patient or osteoporotic patient, minor injuries can cause really significant fractures. So that's just a good rule of thumb to know. Patient with a high fall, falling off a ladder, falling off a roof, falling down steps, motor vehicle collision, getting hit by a car, those can cause major pelvic fractures in anybody. Getting hit by a car is something that is more commonly seen in pediatrics. Why? They're just out in the streets often playing, and they're maybe a little bit shorter, not making the wisest decisions maybe because they're kids. Maybe their parents aren't making the wisest decisions, but they tend to get hit by cars often. So that's something that you can commonly see in pediatric situations. Symptoms. This is going to depend on the severity. Pretty much everybody, if they have a pelvic fracture, they're going to have some level of pain. You're not going to necessarily see inflammation as we see in a lot of fractures because the pelvic bone is so is buried. Anteriorly, it's buried behind abdominal muscles. Posteriorly, it's buried behind your buttocks. So you may not see any swelling, but what you will see always in a patient with a pelvic fracture is pain and inability to bear weight, if they're even able to walk at all. You may also see the legs held in external rotation, and as was previously mentioned, that's just due to the the fracture and to the ligament problems that can result from that fracture. It's not able to hold the femur in its normal place. The femur just naturally will rotate out externally. A limb length discrepancy can also indicate a pelvic fracture, and then of course lacerations and bruising, which are nonspecific signs of trauma. Very important to remember that, especially for the USMLE, because they might want to try to trip you up with this, the most important initial step is for management is to resuscitate the patient, and that goes obviously for any injury or any sickness that may come across. You always want to make sure that you're taking care of the ABCs: airway, breathing, and circulation, and mostly focusing with pelvic fracture on the circulation. What you can get in real significant cases, really bad cases of pelvic fracture, are venous injury and, as a result, hemorrhage. And so you want to make sure that you're keeping an eye on the patient's blood pressure, just so you're keeping any kind of complication at bay. Large bore IVs should be inserted in any patient who comes across with a significant injury, and fluids should be administered if the patient shows any sign of possible hypotension. Initial physical examination. Okay, this is going to be the big important part of the patient with pelvic fracture, because what we're looking for here are complications. And the complications are arteriovenous, neurological, urological, musculoskeletal. And so the physical examination, the initial physical examination, which you want to do very promptly, is super important. So what are we doing with that initial physical examination? First off, we're doing a general inspection. So this is just you looking at the patient. You don't have to touch the patient, you're just looking at the patient. What you want to look for is presence of external rotation or a limb length discrepancy, and that is an indication of pelvic fracture because of the injury itself. You want to look for bruisings, lacerations. Also, particularly, you want to look for ecchymoses and hematomas. So ecchymoses and hematomas are signs of vascular injury, particularly the hematomas. I'm going to show you a picture of a scrotal hematoma, just to warn you. That is a sign of vascular injury. And the reason we want to pick this out right away, if there's any kind of possible vascular injury, this patient's going to be on the fast track for some emergent vascular surgery. So we want to pick this out as quickly as we can. When you do your manual palpation, which should be your next step, you want to just gently palpate the bony structures of the hip, and you're just checking for any kind of abnormality. You want to do this very gently, because if there is a fracture, which there often is, the arteries and veins are often in a very precarious position. And it's not uncommon, if you palpate a little too aggressively, that you may cause more injury or uninjury of the arteries and veins. And so you want to do this very, very gently. You're not feeling deep for any kind of structures down there. That you'll find on the x-ray or on the CT. What you're feeling for with the manual palpation is just anything more peripherally, externally, that you can document. Neurologic exam, we're focusing primarily on L5 and S1, because those are going to be the more overt signs of neurologic damage. So any of the lumbosacral plexus is at risk, but particularly L5 and S1, just because it travels so closely to the bone relative to the rest of the lumbosacral plexus. So L5, remember, supplies the common fibular nerve, which is the nerve that supplies the anterior compartment of the leg, and those are the muscles that are responsible for dorsiflexion of the leg. So if you lose those, what do you have? You have a foot drop. The buttock and perianal sensation are supplied by the inferior cluneal nerve, and that receives its nerves from S1. So if there's any kind of numbness around the anus or in the buttocks, that indicates likely S1 damage. S2, S3, and S4 damage can be noted if there's any kind of loss of rectal tone, and that's supplied by the pudendal nerve. S2, 3, 4, get your pants on the floor. The pudendal nerve supplies your some of your genital nerves, and it also supplies the rectal tone. And then saddle anesthesia, that's more indicative of lower sacral damage, so S3 through S5. Remember what we also see saddle anesthesia in? We see it in conus medullaris. We see it in other lower sacral disorders, cauda equina syndrome, and so forth. So those are all some things to keep in mind when you're doing your physical examination. And then also importantly, the urogenital examination. So the prostate exam in men, something to keep an eye on is a boggy prostate. Boggy prostate would indicate not necessarily damage to the prostate itself, but arterial or venous damage, and that would then bleed into the prostate. I suppose you're not going to keep an eye on it, you're going to keep a finger on it as you do your rectal examination. When you do your rectal examination, you're also, of course, checking for rectal tone loss. Bimanual examination is of the utmost importance in women, and the reason here is not just because of bleeding or because of damage to the structures of the vagina or the cervix, but because when you look at a woman, you're looking at her vagina, you aren't seeing everything. When you look at a man and you look at his penis and his scrotum, you're seeing everything. When you look at a woman's vagina, you are not seeing everything. There is a cavity in there, and within that cavity, there may be bleeding, and more importantly, there may be an open fracture. And an open fracture mandates open reduction and internal fixation as the treatment. And also an open fracture is associated with more complications. And you're probably going to want to have a gynecologic surgeon on board if there is an open fracture of the vaginal vault, just because there can be problems there that they're going to want to manage. So this physical examination, this is just the basic physical examination for a patient that you suspect or know that there's a pelvic fracture, just because this is going to address most of your complications. So here's external rotation and limb shortening. And then here is a scrotal hematoma. This patient also has some fixators, external fixators. We tend to shy away from those now. So pelvic fracture, the best initial step in diagnosis, so not in management. Of course, in management, it's going to be resuscitation. The best initial step in diagnosis is imaging. Now, this can be done either by X-ray or by CT. By X-ray, we want to make sure that we're getting multiple images, as we would in any fracture, but with the pelvis, because this is such a three-dimensional bone or structure, we have to get multiple images. We have to get AP, we have to get lateral. We also want a view of the inlet and a view of the outlet. So because there's all these X-rays, and because some pelvic fractures can be really complicated, a lot of times we just go straight to CT. So in more significant injuries, it's easier to just go straight to CT. CT is also a better imaging modality because it's easier to pick up on some of the things that might be a little bit more subtle on an X-ray. So in more significant injuries, definitely go with CT. If it's a less significant or less pressing issue, then you can go with an X-ray or a CT. In addition to imaging, you want to have a urinalysis. What we're looking for here is hematuria, or that can be either microscopic or gross, and that's going to indicate bladder or urethral injury, which can happen with pelvic fracture. We also want to have routine labs. That's also to see if there's any blood loss, and also to get a cross type. So in the event that we have to either now or later have to transfuse the patient, we know what the blood type is and make sure that we have that ready. And then investigation and management of other sustained injuries. A lot of patients who have pelvic fractures, significant pelvic fractures, they get them in motor vehicle accidents, and so the pelvis is not the only structure that's at risk. So this is a normal pelvis x-ray, and you really need to know what a normal pelvis x-ray looks like. You should know what any normal x-ray looks like. So I want to point out some structures on the x-ray. I also pointed them out in the anatomy recap, but I want to point them out here because these are the most commonly damaged sites of the pelvis. So first we have the sacroiliac joint. So here's the sacrum here medially, and then here's the ilium here laterally. Now, there is this little tiny separation, and that's the sacroiliac joint, and it should be no more than 2 millimeters, maybe even less. A lot of times, sometimes you might not even see a separation. So this little tiny separation is your sacroiliac joint. The iliac crest is this sort of more, a little bit more prominent ridge here at the top of the ilium. And then the iliac wing, which is the main body of the bone. Down here we have the ischium. That's the inferior part of the pelvis. And then the symphysis pubis. And then this is the pubic bone itself up here. And the symphysis pubis should be no more than 5 millimeters separated in an adult and no more than 10 millimeters separated in a child. And by child, I mean just not skeletally mature. Okay, so here's a pelvic fracture. And this is a symphysis pubis disruption. This is the easiest one to pick up on X-ray, simply because it's very straightforward. So you know that your symphysis pubis should be no more than 5 millimeters separated in an adult. This is obviously much more than 5 millimeters. So this is a symphysis pubis disruption. This is most commonly caused from straight-on anterior or posterior trauma. This is a sacroiliac joint disruption. So remember, your sacroiliac joint should be no more than 2 millimeters separated. And this is a difficult one to pick up on, a lot more difficult than the symphysis pubis because it's a smaller joint. And if you can have 4 millimeters of separation, and that would be disruption. It would be fracture of the pelvis. So this is magnified, and you can see here that you got a little bit more separation on the left than on the right. So here's a pelvic fracture. This is a bilateral sacral wing fracture. It's you got it on both sides, pretty much symmetrical here, but you can see here that the sacral wing is fractured straight down. And then this is an ischial fracture. So remember, your ischium is this most inferior bone, and so here it is on the right. This is the fracture right here. And one of the reasons I should point out that pelvic fractures can be difficult to pick up on is because bowel gas kind of obscures the pelvis. So this is another reason why CTs are kind of a little bit better to get, because with CTs it's easier to find these fractures than with plain film X-rays, where you can get a lot of other stuff that you don't want clouding your view. So here's a symphysis pubis disruption right here. Okay, now here we have a more complicated problem. We have a sacroiliac joint disruption right here. It's separated. And then we also have a fracture of the sacroiliac joint right here. These two bones here should be together. And then, of course, we also have a symphysis pubis disruption. And this also illustrates why it's important to have multiple views, because we can't really see what direction these bones are going in. Here's a sacroiliac joint disruption. So you can see here, it's kind of obscured by bowel gas, but you can see here that you've got separation here. on the left side. On the right side, perfectly normal. On the left side, disruption. And then you also have Symhysis pubis disruption. Here you have Sacroiliac Joint disruption on the left. You also have an ischial fracture down here. And you also have Symhysis pubis disruption. Here we have a bilateral pubic crust fracture. So here's your pubic crust up here, and then I'm pretty sure we have it down here. It'd be right here. Not exactly sure. I didn't read the radiologist report on any of these x-rays that I found. So this is just my interpretation. I'm not a radiologist, but I think I'm pretty good at reading these. And then you also have a Symhysis pubis disruption, mostly because you've got all these other problems, all these other fractures. And of course, these are just zippers and buttons on the person's pants. And then here, this is the fracture that is commonly misdiagnosed, or undiagnosed, I should say. So this is an avulsion fracture. See if you can see where it is. Okay, now the iliac crest is the most common place to get the avulsion fracture on the pelvis. And the reason, of course, is because, as mentioned, the iliac crest is the insertion point for a lot of muscles. And what an avulsion fracture is, if you remember back to general fractures, is it's when the muscle pulls away from the bone and it actually tears some of the bone away from the rest of the bone. And so here's your avulsion fracture right here. Just a little tiny fracture. And this is not going to present as, probably is not going to present as a lot of difficulty walking. It'll present as pain, but it's definitely not going to present as, I would imagine that it would not present as external rotation. This is a kind of nice x-ray. You can see here you got your lesser trochanter and your greater trochanter on both sides. Some x-rays that can be really difficult to see, so just to point out. Okay. So the pelvic fracture, the best treatment, as mentioned, the initial step in management is resuscitation as necessary. And anytime you're giving a patient fluids, especially in a traumatic setting, you should also insert a Foley catheter. But that should only be done after you've ruled out urethral injury. And generally you can rule out urethral injury on your physical examination, and if the patient can void urine, that is not bloody. Definitive therapy is done either by external fixation, as we saw with that patient with the big scrotal hematoma, or by open reduction and internal fixation. Because surgeons have gotten so good at open reduction and internal fixation, and the technology is so much better, it's become preferred to do open reduction and internal fixation for a pelvic fracture. So for any of the real significant injuries, and I would even say for some of the minor injuries that are causing impairment, open reduction and internal fixation is the preferred treatment, just because it's associated with a better recovery, it's associated with more mobility afterwards, and with external fixation, one of the big complications of that is infection around the site of fixation, because remember, you're poking a big rod into the patient's skin, and so that can get infected. DVT prophylaxis is also very important with a pelvis fracture, because these patients are going to be immobile for quite a while, because these fractures are going to make it really impossible to walk. So you want to make sure that you're giving the patient heparin or fractionated heparin, so something like Lovenox. And then pain meds as needed. Obviously, with real big fractures, the patients are going to be screaming at you, so you'll want to give them their morphine, something for pain. What are the complications of a pelvic fracture? So remember that we were looking at these immediately when the patient came in with our initial physical examination. Now this is showing you what the problems are. So first off, most importantly, because it is the #1 cause of mortality in patients with significant pelvic fractures, is vascular injury. We see venous injury far more than arterial injury with pelvic fractures. The way you're going to manage this is just hemodynamic monitoring, also getting serial hematocrits. and of course, especially in more severe cases, always in more severe cases. If they have, the initial treatment for that, of course, is going to be IV fluids, but if there's real significant blood loss, we want to also replace the blood itself, and we'll give packed red blood cells, fresh frozen plasma, and platelets at a 1-to-1-to-1 ratio. And the literature has demonstrated that a 1-to-1-to-1 ratio is the best ratio to administer these blood products to improve the survival rate. And then urethral injury, if hematuria is present or if the Foley catheter cannot be placed, you'll want to consult with a urologist. And that's important because just because urethra is so commonly damaged, so the urologist is going to manage that. They'll do a retrograde urethrogram. The retrograde urethrogram will show exactly where the urethral injury is, and then they'll be able to repair it. Neurologic problem. Also, I should mention with urethral injury, also genital injury in women. That's very common, so you'll also want to be looking out for that. Neurologic injury, L5 and S1 are the most common nerve roots at risk. L5, as previously mentioned, supplies the anterior compartment of the leg, and that those are your extensors. So if you lose those, you'll go straight into plantar flexion, and that's a foot drop. If you have damage to S1, that's going to cause reduced perianal sensation. General postoperative complications, as in any patient who's getting a major surgery, atelectasis, wound infection, UTI, DVT, those are all things that we can avoid in most cases, but they are possible complications. And then structural complications after surgery would be abdominal hernia and bowel herniation, more so due to the incision site rather than to the pelvic fracture itself.